Alright you guys, welcome back to another video lesson from ICU Advantage. My name is Eddie Watson, and my goal is to give you guys the confidence to succeed in the ICU by making these complex critical care subjects easy to understand. Alright everyone, this lesson here is going to be the complete CRRT Explained series all in one video. All 6 lessons from that series are here back to back, and we'll cover everything you need to know for a good solid foundation in CRRT. From our renal system anatomy and physiology, through the different principles of CRRT, the different modes that we can operate in, as well as a discussion of anticoagulation, and a fairly comprehensive collection of pearls that have just been learned over the years. Now, if you'd also like to earn CE credits for watching this series, then you can simply become a member of ICU Advantage Academy at icuadvantage.com/academy, or follow the link down below and join in there. Now, as an Academy member, you're also going to have access to the brand new and beautifully designed premium notes that I'm working on redesigning. That said, you can also pick up a copy of these CRRT premium notes by following the link down below. Now, if you don't want or need CE credits but still would like access to the original style notes as well as audio-only versions of my lessons, you can also become a YouTube or Patreon member and access all the notes as well as all those audio versions of the lessons for the entire channel. You'll find links to both of those down below as well. I hope you guys enjoy this master cut on many aspects of CRRT that are foundational and important for you to know. Alright, so in this lesson here today, this is going to be the first lesson in a series of lessons talking about continuous renal replacement therapy, or CRRT. Now, before we get into talking about this therapy though, it helps to have a good understanding of the normal anatomy and physiology of the renal system to really better understand what it is that we're trying to accomplish with this. And that's the point of this lesson here, is to go over this renal system review. Now, this lesson is not going to go too in depth, as I know most of you have already had the anatomy and physiology class, but I am going to review through some of the helpful information. And so to start, let's begin talking about some of our renal anatomy. Now, as we know, the organ of the renal system is the kidney, which we have 2 of. They sit in our retroperitoneal cavity on each side of the spine between the 12th thoracic and 3rd lumbar vertebrae. And just interesting to note, the right kidney is actually lower than the left due to the placement of the liver. Now, we can divide the kidney up into 3 layers. We have the cortex, which is this outer layer here. Next, we have the medulla, which is going to be this inner sort of open section here. And then finally, we have the renal pelvis, which is going to be this area here. And this is where the urine is collected and sent to the urethra. Now, the cortex and the medulla, they contain various parts of the nephron, which is actually what we're going to talk about here next. And so the nephron, this is our functional unit of our kidney. And so what's really interesting is that each kidney contains more than 1 million of these nephron units in it. And collectively together, that they work to maintain the water, electrolyte, waste, and acid-base balance in our body. And the way that they do that is through this pretty complex structure that you see that I have the picture of here. And so let's go through and talk about some of the different parts of this pretty complex nephron structure. So the first is going to be this big capsule-like structure here. And this is going to be something that we call the glomerulus. And as you can see, it's surrounded by this membrane, something that we call the Bowman's capsule. Now, the first section coming out of the glomerulus is going to be our proximal tubule. And then continuing on from here, this is actually still technically part of the proximal tubule, but this is something that we call the loop of Henle. And the loop of Henle is composed of 3 sections. We have the thin descending loop, the thin ascending loop, and then the thick ascending loop. And then from here, we go on to the distal convoluted tubule before finally going into the collecting tubule and the collecting duct. Now, important to go along with the tubules of the nephron is also going to be the renal blood supply that we have going through here. And interestingly, 20 to 25% of cardiac output is going specifically to the kidneys. And so everything really begins with the renal artery branching off the aorta. And so we can see that coming in on the image here on the right. And then from there, it's going to branch down until we have something that we call the afferent arterioles. And this afferent arteriole is going to be what enters the Bowman capsule and really helps to form that glomerulus. Now from there, the blood is going to exit the glomerulus via what we call the efferent arteriole. And then the efferent arteriole is going to become this pretty big complex, something that we call the peritubular capillaries. And really these peritubular capillaries are going to interface with all the different parts of the tubules to continue to perform functions that need to happen within the nephron. Alright, so now that we have the basic structures out of the way, let's talk about the actual renal physiology that's taking place here. And so the main goal of the kidney here is to filter the blood and form urine. Again, like I said, in this process, the nephron is going to be regulating water, electrolytes, waste, and the acid-base imbalance. So, like I just talked about, the afferent arteriole is what goes in and forms the glomerulus, which is actually a high-pressure capillary bed to which then the blood exits via that efferent arteriole. Now here the afferent arteriole is actually a larger diameter than the efferent arteriole, and this is what allows a greater volume of blood to enter the glomerulus than what's actually exiting, and this is going to create a high pressure. And it's specifically this high pressure that creates the hydrostatic pressure, allowing water to be filtered across the basement membrane. And so then the basement membrane of the glomerulus is actually a semi-permeable membrane, and it's going to allow all but the larger molecules to pass through it. So think here we're excluding things like protein, albumin, red blood cells. And so here we're going to have particles that are small enough to pass across the basement membrane, which are going to be moving from areas of higher concentration to lower concentration. And this is also something that we call diffusion. Now on top of that, if we have enough water that's being forced across that membrane via that hydrostatic pressure that we just talked about, additional particles or solutes are also going to be dragged along with it, something that we call convection. And so typically with our kidneys, large volumes of water are going to be filtered, allowing for this additional waste clearance that we see. So now we have blood that's left with these large molecules and proteins, and it's going to be leaving via that efferent arteriole. Now, having these large molecules and proteins in there is actually going to provide oncotic pressure for water and solutes to be reabsorbed in those peritubular capillaries. And so as you can see, the blood that's exiting via the efferent arteriole is still oxygenated blood. And so in addition to also going into those peritubular capillaries, another responsibility that it has is to actually perfuse the kidney itself. And that's why finally at the end here, we do see the blood becoming deoxygenated as it goes out into a vein. Alright, so like we talked about, we have that high volume of water filtrate that has left out of the glomerulus, and first we're going to enter into the proximal tubule, and this is going to be responsible for the reabsorption of water and important solutes and electrolytes. And here we're talking about things like potassium, sodium, chloride, glucose, and bicarbonate. Now on top of this reabsorption, we also have hydrogen ions that are going to be passively secreted here. Now continuing on, we actually have different nephrons that have different responsibilities for what actually takes place in the loop of Henle. So we have shorter cortical nephrons, which are going to focus on the excretion and regulatory functions, while we have longer juxtamedullary nephrons, which either dilute or concentrate the urine depending on what needs to happen. Now, if you remember looking at the loop of Henle, there's a big distinction between parts 1 and 2 and part 3 in terms of the thickness, and it's this thickness of the loop of Henle that actually impacts the permeability of the membrane, allowing it to do different things. So then moving on, we have the distal convoluted tubule, which plays an important role in the regulation of blood pressure, while also regulating solutes by absorbing or excreting them in this section. And in this section, we also have the antidiuretic hormone, or ADH, which aids in water reabsorption towards the end of this distal convoluted tubule. Now, we do see some bicarb being reabsorbed here, as well as hydrogen ions being actively secreted. And then the main waste products that we're looking to excrete through this active filtration by the nephron are going to be our BUN, uric acid, and creatine. And so as you can see, the kidney and their functional units, the nephrons, really play that vital role in the homeostasis of our bodies. They're regulating the fluid balance by controlling how much water is reabsorbed. Waste, electrolytes, and solutes are going to be filtered out, but then the regulation of the electrolyte solute reabsorption is going to take place to ensure that our body has proper levels. And then also through the reabsorption of bicarb and the secretion of those hydrogen ions, they're going to be working to regulate the body's acid-base imbalance. And so when our patients go into acute kidney injury and ultimately renal failure, this important regulation really becomes ineffective or non-existent. And in order for us to be able to support these patients, we really need to recreate the work of what's happening inside this nephron. And so much of what we attempt to do with the therapies that we offer is based on what the natural nephron is doing. And therefore, having an understanding of what normally happens in here is going to be important to understand the how and why the therapy that we provide does what it does. And so that's why I wanted to do this renal system review for you guys, so that you had this understanding of what was going on here, because as we move forward and begin to talk about CRRT and how that works, much of what's going on there is really driven with the purpose of trying to recreate what happens here so that we can effectively filter the body's waste, as well as controlling the fluid balance, as well as the electrolyte and solute balance of the body, as well as having an impact on our patient's acid-base balance. So I hope this was a good quick review of what's going on here in the renal system. Like I said, we're going to apply this information moving forward, continuing on the CRRT lessons. Alright, so this is going to be a continuation on the series here talking about CRRT and really explaining what this therapy is. In the second lesson here, what we're going to talk about is what exactly CRRT is. I'm going to explain what the therapy is, why it is that we use it, and give you some basic info really about the therapy and the setup of everything. Over the next few lessons, we're going to dive deeper into the principles and the type of therapy that we really can offer these patients, so make sure and follow along and stay tuned. Alright, and so let's go ahead and get started here, and let's start off talking about what exactly is CRRT. So CRRT stands for Continuous Renal Replacement Therapy. And so CRRT is a therapy that really is in the same class as our intermittent hemodialysis, IHD, or our peritoneal dialysis, PD. And so what CRRT is designed for is for the critically ill patient who oftentimes is unable to tolerate the rapid, short iterations and the accompanying fluid and electrolyte shifts that we typically will see with intermittent hemodialysis. And so, as its name suggests, instead of the typical 3 to 4 hour run times that we see with normal dialysis, CRRT is running continuously, 24 hours a day. And so this is going to be better tolerated by our unstable patients. And so just as with regular dialysis, the goal of CRRT is to remove toxins, excess fluid, and really balance our electrolytes. And our goal is to mimic the job of the failing kidneys. It does this by reproducing the various functions that we saw in the nephron that I talked about in that first lesson. Now, it is important to know, though, that not all facilities offer CRRT. Oftentimes in these cases, when we have these critically ill, unstable patients, is we're going to offer them a different type of therapy that we call SLED, which stands for Slow, Low, Efficient Dialysis. And these are runs that last anywhere from 6 to 8 hours and are oftentimes done every single day for these patients. So as you can see, that'd be a pretty resource and time-heavy commitment for these patients, but in facilities where you just don't have a CRRT available to you, this is a really good option for these unstable patients. Now, in order to operate the CRRT machine, as well as to take care of the patient that's receiving the therapy, it really requires specialized nurses who have been trained in this therapy, as well as the physiological impact that this therapy is going to have on the patient. Now, these patients are often very sick and, to be honest, quite time-consuming. And in many facilities, these patients who are on CRRT are staffed as one-to-ones. And so the next question we want to ask is, why is it that we use CRRT? And so I really hit on some of this already, but we're going to use CRRT in the critically ill, unstable patient who have AKI, or acute kidney injury, and are in acute kidney failure, or in patients who are end-stage renal patients who receive dialysis who are also too unstable to receive normal IHD. And then just to list out some of the main indications for renal replacement therapy, which would also include CRRT in those critically ill, unstable patients, are going to be things like elevated toxins, so our creatinine and BUN, fluid volume overload, severe electrolyte imbalances, and some acid-base imbalances. Now, those are the primary indications, but we also find that we can use CRRT for patients in sepsis to aid with the cytokine clearance, patients who have rhabdomyolysis, CHF, and even post-open heart surgery. And then given that these patients are pretty sick, typically these patients are going to be hemodynamically unstable and they're going to be requiring pressors to maintain an adequate blood pressure. And one of the really nice things about CRRT is that because it's continuously running, we can make changes to the therapy at any time. And so we can adapt to really rapidly changing situations that are being presented with these critically ill patients. So that's kind of the quick down and dirty on what really CRRT is and why it is that we're going to use it. And so then let's move on and talk about really the basics of the machine and the circuit setup for running these patients on CRRT. So what we're going to do is we're going to talk about the arrangement of the machine and the circuit and really how it is that we run the therapy through here. There are different types of therapy which use some or all the parts that I'm going to talk about here. And I am going to discuss those in the next lesson, but for now let's just review the entire setup. Now there's really 3 main machines that are used most often. 4 if you want to count the most recent upgrade to one of them. And honestly there may be others, but these are the 3 that I've seen. Now, the first and most popular of these is actually going to be by a company called Baxter, and this is going to be the more common and older machine, which is the PrismaFlex, as well as their new PrisMax. Then we have the Edwards Lifescience Aquarius, and I believe this machine and its business was actually purchased by Baxter some years ago, so these might be just eventually working their way out into the newer Baxter machines. And then the other one is going to be something called NextStage. Now, each facility that I've worked at has used the Baxter PrismaFlex, and then now we're starting to get in some of the new PrisMax machines. The Aquarius is actually very similar in the machine configuration to the PrismaFlex PrisMax. Now, I did spend a little bit of time moonlighting at a facility that used NextStage. I didn't get to the point to where I was actually doing this therapy on those patients there, but this machine seemed simpler to use and required less work from the ICU nurse from what I saw. Now, the operation of the NextStage was slightly different than what I was used to with the PrismaFlex, but really the basics I'm going to talk about here and the principles discussed in this lesson, as well as the next couple lessons, are still going to apply to nurses who are running therapy through that machine. Now, with all that said, I'm going to base my example here on the Baxter machine. And honestly, part of this is because of the simplicity and really just the availability and the wide use of this machine, as well as just my personal experience and knowing this machine much better. Now, again, each of these machines essentially has the same parts or really functions in much the same way. All right, so when we talk about CRRT therapy, the first thing that we have to talk about is our access. In order to operate, we need to be able to remove blood from the patient, run it through our CRRT machine, and then return that filtered blood back to the patient. Now, most patients that are going to be running with this are going to be newly placed temporary catheters. And these are typically 12 or 14 gauge double lumen catheters. And these catheters are going to be placed in a vein, most commonly in either the internal jugular, subclavian, or femoral veins. Now, these can be either tunneled or non-tunneled, but again, typically most are not going to be. And so for our example here, I'm going to have a right IJ double lumen HD line. Now on this catheter, there is going to be an access and a return line on the catheter. And typically these are going to be color-coded, red for access and blue for return. And so for this catheter, we really want to make sure that we're using the proper ports that are going to our circuit. And to really help better illustrate this, let me draw a quick example of what the catheter is like internally. And so what happens is we have the return lumen that's exiting at the distal part of this catheter, and then the access line is going to draw from more proximal ports. And the reason that this is that we're trying to minimize drawing any already filtered blood back into the system, which if we do that is really just going to reduce the efficiency of what our run is able to do. All right, so now that we have the talk about access out of the way, the first part of the machine that I actually want to talk about is going to be the blood pump. And so this pump here is a roller pump, and this is going to create negative pressure on the patient side to draw blood from the patient, and then positive pressure on the machine side to drive that blood through the filter and then return it to the patient. Now for the blood pump, typically we're going to see blood flow rates that are anywhere from 150 to 300 milliliters per minute, but we can actually have much higher flow rates that can be achieved with this, although we typically aren't going to run the therapy this way. All right, so the next thing along on the machine that I want to talk about is going to be our actual filter. And this filter is actually going to be very similar to a typical dialysis filter. And for these, there are different types that have slightly different purposes. But the one thing that they have in common is they're actually filled with thousands of hollow fiber membrane tubes. And I'm going to put up a picture here to hopefully show you kind of what that actually looks like. And if you really look at it up close, it really looks like thousands of tiny hairs. And so what we get is the blood flows up from the bottom to top inside of those tiny fibers. And it's here in this filter where all the magic is going to be taking place. All right, and so now we're going to have filtered blood that's now coming out of our filter here. And the next stop is to go through some sort of air removal, or in the case of the Baxter, this deaeration chamber. It's going to continue on from there, and then it's going to reach the safety clamp. And the safety clamp is really going to be the last stop if it detects air or some other critical issue that's really going to stop the machine and stop the blood flowing to the patient. Now, one thing to note real quick is I did draw this with red and blue, which typically we see when we're talking about circulation in the body, denoting oxygenated and deoxygenated blood, but that's not the case here. We're going to have the same oxygen content of the blood that's coming out of the filter as what first went into it, but these are the color schemes that these machines use to really identify which is your access line and which is your return line. So like I said, the access is going to be red and that return is going to be blue. So now let's actually talk about some of the different fluids that we use and the pumps that help to drive all this. Now on this system, there's 3 different types of fluids that we can use, and each is going to have its own dedicated pump. And I'm going to color coordinate these with the same colors that we see again on the Prismaflex machine. First, we have our pre-blood pump, which is our pre-replacement solution. Then we have our dialysate, and then we have our post-filter replacement fluid. So first let's talk about the dialysate here. So this is going to flow with the help of our pump to the top of the filter, and this is going to flow top to bottom in the filter on the outside of those hollow fibers carrying the blood. And then this now filter dialysate is going to exit the bottom of the filter in what we call the effluent line. Now this effluent drainage is actually going to be controlled by another pump, what we call the effluent pump. And it's really this pump that is going to be responsible for pulling the plasma water out of the patient's blood across that filter membrane. Again, this is going to be something I'm going to talk more in depth into the next coming lessons here. But so the effluent is going to move past the effluent pump and then make its way to the effluent drainage bag. All right, so now let's go on and talk about the pre-blood pump or the pre-replacement fluid. And this one's actually going to travel a long way. The pump is going to move it along and it's going to connect with the access line just after we draw the blood from the patient. And therefore, we're going to be infusing this fluid before it gets to the filter. And then finally, we have our post-filter replacement. And so again, we're going to have the pump that's going to move this fluid along, and it's going to meet up in the case here right at the point which the blood is going into the deaeration chamber. And so then this means that this fluid is being mixed with the blood after the filter and just prior to going to the patient. Now, when we talk about these different replacement fluids and the dialysate, there's many different types of solution that we can use for these fluids. Now, we do have pre-made solutions for this that actually have like particular balances of electrolytes and bicarb, or your pharmacy can mix up special bags, or even you can use some various standard fluids in certain cases. So again, I'm going to discuss some of those differences on when and why you would use them in the later lessons in this series. Now, one last bit of solution or fluid that we really could include in this system is going to be our anticoagulation. And this is actually going to be a topic that I'm going to dedicate an entire lesson to. But know that there is an option to use a heparin syringe or some other form of anticoagulation to be given to the blood prior to entering the filter. And typically this is, if we're using the syringe pump, it's going to be just prior to the filter, or in other cases, we actually put a Y connector up on the access line and infuse it way back there. All right, the next important part of this whole circuit and this setup is actually going to be our pressure monitoring. So we monitor the pressure at various points in this system, and there's really 4 main pressures that we're monitoring. First, we have our access pressure, and this is going to be the pressure required to pull the blood from the patient, and this one's always going to be negative. Next, we have our pre-filter pressure, and this is going to be the pressure required to move the blood up through those hollow membrane fibers. This one's always going to be positive. And then we have our return pressure. And then this one's monitoring the pressure required to return the blood back to the patient. And again, this one's always going to be positive. And then finally, we have our effluent pressure. And this is going to be the pressure required to pull the plasma water from the blood. Typically, this one is going to be negative, but from time to time, it can be slightly positive. Not usually though, and in most cases, you're going to have a negative value here. And so this here is the basic overall setup of our CRRT machine and our circuit, what different parts and fluids we have coming in and where they're going in, and kind of what's happening at various points along the way within this machine. Now, I know it looks kind of crazy on here, a lot of things going on, but as we go through the next few lessons here, I'm really going to be talking about the different types of therapies and the way that we run the machine. You'll have a good understanding of why it is we would do certain things at certain points to really help and aid in the process of filtering our patient's blood. So hopefully this lesson, though, at least gave you a good understanding of, again, what exactly CRRT is, the indications and why we're using it, and then give you a good overview of how this circuit is set up so that as we talk through some of these next steps, you'll have an understanding of where this stuff is taking place. All right, so in this lesson, we're going to be discussing the basic principles that apply to CRRT. These principles are going to help us to better understand how it is that we're able to filter the blood and essentially mimic the job of the nephron. Understanding these principles is fundamental to understanding how CRRT does its job, as well as the various impacts of the different solutions that we use for this machine. Now, these principles will also help you understand the different types of therapy that we can offer, which I am going to talk about in the next lesson. Now, if you remember from the first lesson, the main job of the kidney and the nephron is to maintain fluid, electrolyte, waste, and acid-base balance. And we can mimic these functions through 4 primary methods, which I'm going to talk about here. And they are diffusion, ultrafiltration, convection, and adsorption. And so first, let's start talking about diffusion. All right, so this is the movement of particles, something we also call solutes, from an area of higher concentration to an area of lower concentration across a semi-permeable membrane. And so this is an example of a semi-permeable membrane that we're dealing with when we have CRRT. So over here on the left side, this is where we have our patient's blood. And if you remember from the last lesson where we talked about the basic setup of the CRRT circuit, that the blood is going to flow through the filter from bottom to top. And on the right side, this is where we're going to have our dialysate. And if you remember, we have this flowing top to bottom. Now remember that the blood is flowing in those hollow fiber semi-permeable membrane tubes, but essentially the material that makes up that tube is actually a semi-permeable membrane, which is what we have here. And it's this semi-permeable membrane that's going to allow for selective diffusion. And then really it's the concentration of solutes that are in the dialysate that is what drives the concentration gradient. So as you can see from the picture here, we have less solute in the dialysate and more in the patient's blood. So because of that change, that difference in the concentration gradient, those solutes are going to diffuse across that semi-permeable membrane to reach a state of equilibrium. Now, as I just mentioned, we have the blood and the dialysate flowing in countercurrent directions. So the reason that we have this is that by having these flows going countercurrent is it's actually going to promote the continual clearance, and it does this by ensuring an adequate diffusion gradient is maintained the whole way through. So I know that sounds a little complicated, so let me kind of illustrate that to help make the point. So let's say here we have a semi-permeable membrane, and we've got again our blood on the left side and the dialysate on the right side. And we know that starting out that the blood is going to have higher concentrations of solute compared to the dialysate. So now if we had both of these flows going in the same direction, as that diffusion is taking place, we'd see the concentration of solutes in the dialysate increasing, and then the blood, which is moving along in the same direction, as it works its way towards the end, because of the high concentration of solutes in the dialysate, we're going to have less of a concentration gradient going on, and therefore we're going to see less clearance out of the blood towards the end of the filter. And so as we go along, those concentrations are decreasing in the blood, but they're also increasing in the dialysate, and this is going to make it harder to get that last little bit of diffusion to take place. Whereas if we have the dialysate flowing in the opposite direction of the blood, when that blood reaches the end of the filter and it has a lower amount of solute concentration, instead of having a dialysate with a high concentration of solutes that we see in the example here, instead, we're going to have it interacting with dialysate with a very low concentration, still giving us that concentration gradient, and as it continues to move down, we still remain with a lower concentration than what's in the blood. And so thus, by having this countercurrent flow, we can get the maximum amount of solute clearance through diffusion. So hopefully that makes sense for you guys. So as you can see from the drawing here in the blood, we have things like blood cells and large molecules such as proteins that are going to be too big to cross the membrane. Therefore, only the desired solutes are going to be able to cross. So diffusion is going to be effective at clearing small molecules, but not large ones. And really the size and type of membrane is going to impact this clearance. Essentially, the filter's permeability is going to be affected by things like our filter pore size, the number of pores that we find in that membrane, as well as just the general membrane thickness. And this all does vary based on the type of filter that you're using. Now, like I said, the concentration of solutes in the dialysate is what's going to drive that concentration gradient. And for our dialysate solution, this is typically going to contain concentrations of sodium, chloride, and magnesium that are going to be in amounts equal to that of normal serum levels. And so we're only going to see these solutes diffuse in cases where the patient either has high or low concentrations in the blood. Now, the next solute that's probably one of the most important ones that we have in here is actually going to be our potassium. And oftentimes when we're starting patients on CRRT, we're going to see very high levels of potassium. And so what we might actually do is start the patient on a therapy delivering a very low level of potassium in our dialysate. An example of this would be one of our 2K baths. But since the potassium is going to clear pretty quickly, we need to make sure that we're closely monitoring and make that transition to a more normal level, such as one of our 4K baths, as our patients begin to normalize their potassium level. Now, serum bicarb levels are typically going to be low in patients with renal failure, so typically we use a dialysate solution that contains bicarb to aid in the diffusion into the blood. And then finally, waste products such as our urea and our creatinine, they're not going to be present in our dialysate. Therefore, these are going to diffuse and be filtered out of the blood. Now, when we're talking about diffusion that's taking place from blood to dialysate in a filter, this is something that we actually refer to as hemodialysis. All right, so that's the principle of diffusion and hemodialysis. Hopefully that makes sense for you guys, because let's go ahead and move on, and let's talk about the next principle, something that we call ultrafiltration. So one of the keys to this principle is knowing that fluid is able to cross a semi-permeable membrane in response to a pressure gradient. And this pressure gradient can be the result of one of three things. It can be either osmotic pressure, oncotic pressure, or hydrostatic pressure. So now if you remember back to that first lesson when we were talking about the nephron and specifically the function of the glomerulus, we have those efferent arterioles, which is carrying that blood away from the glomerulus, that those were of a smaller size than the afferent arterioles bringing the blood in, as well as they were able to constrict and relax, working to regulate pressure, basically creating hydrostatic pressure in the glomerulus, and this is what would help force water out of the blood. Ultrafiltration is essentially that same process. We're going to be moving fluid through the semi-permeable membrane across a pressure gradient. Now, when talking about our circuit, we can actually create this pressure gradient in a couple different ways. We can either create positive pressure on the blood side, pushing the blood through the filter, or we can create negative pressure via the effluent pump, but either way creating this pressure gradient from one side to the other. And we can adjust both of these pressures to impact the amount of the pressure gradient. And the difference in pressure across this membrane is something that we call our transmembrane pressure, or our TMP. And it's ultimately this TMP that determines the ultrafiltrate production. By adjusting this pressure gradient, either increasing the positive pressure on one side or the negative pressure on the other side, or a combination of the both, we can control the amount of fluid that's removed from the blood and ultimately from the patient. Now, when we have this process of ultrafiltration again within our circuit and a filter, this is something that we call hemofiltration. So the big takeaway here with ultrafiltration and hemofiltration is that it's removing fluid from the blood and ultimately the patient. All right, so let's go ahead and move on. And now let's talk about the principle of convection. And convection is actually tied to hemofiltration, as it is a principle of such. So here with convection, we have a one-way movement of solutes through a semi-permeable membrane with the flow of water. So again, as you can remember with ultrafiltration, we have our water that's moving across our semi-permeable membrane. But if we have enough flow of this water, we're also going to see some of these solutes that move across the membrane with it. And this is something that we refer to as solute drag, as the solutes are being dragged across that membrane with the flow of fluid. Now, when we start talking convection here, this is actually going to be effective at clearing small, medium, and large size molecules that are able to fit through that semi-permeable membrane pore. Now, the greater and faster the flow that we have, the more clearance that we can achieve. And ultimately, the molecule size as well as the membrane type are going to impact the flow of these solutes. Now, because it often requires a large removal of fluid to achieve these flows, this means we're also going to be removing a large volume of fluid from the patient, so then we have to replace this volume back to the patient via the replacement solution. And typically the solution that we're going to use for this replacement solution is going to have the same level of electrolytes and bicarb that we normally find in normal physiology. And if you remember from the last lesson where we were talking about that circuit, we actually have two different spots that we can give this replacement solution to the patient. We can either give it before the filter or after the filter as the blood is returning to the patient. And interestingly, one of the things when I first started doing CRT that really kind of tripped me up was that how adding solution after the filter would have any kind of impact on our solute clearance, as it was just basically going straight to the patient. And I'm going to explain that more here in just a minute, but eventually it was explained properly to me that by adding this fluid, it allowed us to pull more fluid via the hemofiltration, and this resulted in seeing additional convection and ultimately more solute clearance. But at first it seemed quite backwards that by giving them this solution as it was going to the patient, how was this impacting any sort of clearance of solutes? Now, speaking of this replacement solution, we need to talk about something that we refer to as pre-dilution versus post-dilution. So like I said, we can return replacement fluids to the patient's blood either before the filter or after the filter. Before the filter is what we call pre-dilution, and after the filter is what would be our post-dilution. And there are advantages and disadvantages to doing both. Now, if we give this solution pre-dilution via our pre-blood pump or our PBP, that this is going to dilute the blood going into the filter and leads to less solute clearance. But by having dilute blood in the filter, that this is going to help reduce the clotting of the filter and really preserve the life of the circuit. Now on the flip side, if we give this replacement solution post-dilution via our post-filter replacement, then this is going to lead to more concentrated blood in the filter and ultimately it clotting sooner. But having more concentrated blood leads to better solute clearance. So typically when we're starting out, what we actually do is a mix of both. And oftentimes I find that we're going to run, at least starting out, equal amounts of pre and post dilution. And ultimately, the belief tends to be that we actually want a little bit of both. We don't want to give all of the solution either pre or post because of some of those negative consequences. Now, one thing to remember though is we're giving the patients a lot of fluid into their blood via this replacement solution, but all of the volume that we give them is actually going to be pulled off via hemofiltration, so it doesn't have any impact on the patient's fluid volume balance. Our patient's fluid volume is only going to be adjusted by the balance of the overall fluid that we pull off, something that we refer to as the patient fluid removal rate, and this can lead to either positive, negative, or really an equal balance of fluids, although more than often we're running them either equal or negative. So essentially we're usually either keeping them balanced with their fluid state or we're slowly working to remove some fluid. Alright, so hopefully that made sense with convection, and you can see how it's actually tied to the other principle of ultrafiltration. And then finally, the last principle I want to talk about here is something that we call adsorption. Now, adsorption is one of the unique properties of CRRT that we don't fully get with intermittent hemodialysis. Essentially what this is it's the adherence of solutes and other biological matter to the surface of the membrane. So you can imagine that as time goes on, we begin to see things basically adhering or really sticking to our semi-permeable membrane here. And as time goes on, we see this begin to build up. And as we see higher and higher levels of this adsorption taking place, that this can actually lead to something that we call the filter as clogging. Basically, this means it becomes less effective. Now, the membrane type is going to affect these adsorptive properties and really the efficiency of a particular filter to adsorb this material. One really good example of this is something like the CytoSorb filter that's specifically designed to adsorb higher levels of cytokine to aid in patients with cytokine storm. So essentially, some filters are going to have more adsorptive properties than other filters. And this adsorption may have a small effect on the clearance of some solutes from the patient's blood. All right, so those are the 4 principles of CRRT. It's these 4 foundational principles that really guide the different modes of therapy that we run for our patients and really help to mimic the functioning of the nephron and the kidney to ultimately work to filter waste from our patients, control the fluid volume balance, the electrolyte and acid-base imbalance in our patients. Now, there are some things that we do in addition to just these principles that kind of work to ensure that we're achieving the proper levels of electrolytes and acid-base balance, but the core of what CRRT is doing is based on these 4 principles here. In the next lesson, I'm going to be talking about the different modes and therapies that we can offer for CRRT, and you have to have an understanding of these principles to understand how these modes are different from one another. All right, so in this next lesson, this is going to be the 4th lesson in this series on CRRT Explained. And in this lesson, we're going to be discussing the different modes or types of therapy that we can offer with CRRT. This should be a relatively short lesson. Now, in the last lesson in this series, we talked about the principles of CRRT that really guide our therapy and our solute clearance. If you haven't watched that already, please watch that lesson first, as understanding those basic principles is really going to help you to understand how these types of therapy really work and differ from one another. There are several different types of therapy that we can offer with CRRT, and much of it's going to depend on what the patient needs, as well as really the provider preference on how they want to run it. And so let's go ahead and get into talking about these different modes that we have. And it's important to know that the therapy that we can offer people really consists of various applications of either hemofiltration, hemodialysis, or a combination of both, principles which were discussed in great detail in that last lesson. So as we talk about these different modes, I'm going to add them to this chart here so you can really see where they fall in this alignment of either hemofiltration or hemodialysis or some combination of both. Now, as well as when we go through and talk about these different modes, I have the basic circuit set up here with a patient. And again, as you remember from that second lesson, we have our dialysis line with our access line coming off in red. The blood is going through our blood pump, pushing it through the filter, and then from there we have the blood exiting the filter via the return line and going back to the patient. Now, in addition to that, we also have our effluent line coming off of the filter, and this is to collect the filtrate or effluent that we pull off in therapy. So regardless of the different mode that we're going to talk about, all of them are going to have these basic components to them. And then from there, we're going to either add or take away or do some different combination of other things in order to achieve the different principles that we talked about from that last lesson. So as I go through and talk about those, I'm going to include those on here so you can really see how that fits into our CRRT circuit. So the first of these modes that we're going to talk about here is going to be our slow continuous ultrafiltration, or SCUF. Now essentially this is the process of removing fluid, so ultrafiltrate or effluent, at slow rates and without using any replacement fluid. Now this mode uses the principle of ultrafiltration, but because of the slow rate of it, we have little to no solute clearance, aka convection. And so let's go ahead and place this one on our chart here under the hemofiltration. And the main goal of SCUF is going to be the safe removal of fluid from the patient who has fluid overload. Now, when we talk about the setup of our CRRT circuit, we're not going to be using any dialysate nor replacement fluid. So essentially, the circuit that I have shown here as an example is exactly what we're going to have. We're just going to pull blood from the patient, and we're going to pull a small amount of fluid off as effluent. So pretty straightforward. All right, so the next mode that we're going to talk about is going to be our continuous veno-veno hemofiltration, or CVVH. And so here we're going to have the process of both fluid removal as well as solute clearance. The principles that we're going to be using here are both ultrafiltration and convection. And so now, because of the volume of fluid that's going to be removed in order to drive that convection, we must use replacement fluid. And this can be either pre, post, or both. Now again, this is going to remove both the small and large molecules, and we will see the pH will be impacted by the buffer that's being contained in our replacement solution. Now this therapy is going to be indicated in uremia and severe acid-base or electrolyte disorders, or if the removal of large molecules is needed. And for this mode, we're not going to have any dialysate that's used, but we are going to be using replacement fluid. So let's go ahead and add this mode to our chart that we have here. And again, this one's going to be listed under our hemofiltration side. And then if we look at our circuit setup here, we're still going to have the same setup that we have drawn out here. In addition to that, we're going to be adding in some sort of replacement fluid. And there's two different spots that we can be adding this fluid. We can either be adding it pre-dilution, so essentially into the blood before it gets to the filter, or we can be adding it post-dilution to the blood after it's gone through the filter. Or, like I said, some combination of the both. Alright, so let's go ahead and move on, and we'll talk about the next mode that we have here, the continuous veno-veno hemodialysis, or CVVHD. Now this is going to be the process of removing waste products and solutes. And for this mode, we're going to be using the principle of diffusion, also known as hemodialysis. And so let's go ahead and add that one into the chart here under the hemodialysis column. And so here in this mode, we're only going to be removing the small and medium-sized waste products and solutes, as well as our patient's pH is going to be impacted by the buffer that's contained in the solution that we use. Now we can also use this mode to safely remove fluid volume from the patient. So here though, we're going to primarily be using this for patients with uremia and either severe acid-base or electrolyte imbalances. And for this setup here, we're going to be using dialysate, but not replacement fluid. So here we're going to have our dialysate solution, which we're going to infuse into the filter on the outside of those hollow fiber semi-permeable membrane tubes that are carrying the blood. And then that dialysate is going to come out of the filter in the form of the effluent. So you can think here, because we have this dialysate fluid flowing through the filter on the outside of that semi-permeable membrane, we're creating that concentration gradient, thus giving us the diffusion or the hemodialysis, which makes up its name. Alright, and so moving on, we'll talk about the last mode of therapy that we have, something that we call continuous veno-veno hemodialifiltration, or CVVHDF. So here again, this is going to be the process using a combination of principles to remove waste products, solutes, as well as fluid. And so here, the principles that we're going to be using are going to be diffusion, ultrafiltration, as well as convection. Now, one thing I didn't specifically mention in any of these modes here is the principle of adsorption, and that is actually going to be present for all of the modes that we do. Again, really just kind of dependent on the filter type that you're using. If it has more adsorptive properties, then we're going to see those benefits in the therapy. So now let's go ahead and add this mode to our chart here, and as you can see, this one actually uses both hemofiltration as well as hemodialysis, so we're going to have this one straddling the middle of our chart. Now, in my experience though, most patients are typically just ran on this type of therapy. Part of the reason is because it's going to be the most efficient and can contribute both to removing fluid, controlling our patient's fluid balance, as well as that waste and solute clearance. But in addition to that, if we want to change modes for our patient, you can't on some machines add the therapy as you go. You'd have to stop, take down the filter, and reset it up with the new therapy that you want to do, as opposed to if you have the patient running in CVVHDF, you can just turn down the flows to either replacement or dialysate, which would essentially be doing the same thing. So speaking of that, this therapy is going to require both the use of dialysate and replacement fluid. And this therapy is going to be effective at clearing small, medium, and large size molecules. Our patient's pH is going to be impacted by the buffer in the solutions, and we can safely remove fluid from our patients in this mode. And our indications to use this one here is going to be for uremia, severe acid-base and electrolyte imbalances, fluid removal, or when large molecule clearance is necessary. So again, looking back at our circuit setup, we're going to have the use of both the dialysate as well as the replacement solution. And again, we'll have our dialysate going in top to bottom in the filter and coming out as effluent. And then we'll have our replacement solution either going in pre-dilution into the blood before the filter, or running as post-dilution going into the blood after the filter. And so in this mode, we're going to be using all of the different parts and all of the different fluids that we talked about in that second lesson as we went through the full setup of the CRRT circuit. So again, CVVHDF is going to be our most inclusive. It's going to be hitting both the hemofiltration and the hemodialysis, and really providing the most amount of clearance and support for our patients. Alright, so I hope this lesson really kind of clearly explained the differences between the different modes that we have for CRRT, and really also to help you kind of understand which basic principles of CRRT are being used for each mode, and really how that's benefiting our patient. So we've really kind of stepped our way through these first few lessons and kind of talked about, things that built upon one another to get us to the point to where when we talk about these different modes, that you'd have a good understanding of what's happening in each one. There are going to be a few more lessons after this one, which are going to cover different aspects of CRRT therapy, which are going to be certainly beneficial if you're taking care of these patients. So make sure you guys stay tuned in order to catch those future lessons. Alright, so let's go ahead and jump into our lesson here. This is going to be the 5th lesson in the CRRT Explained series, and in this lesson we're going to be talking about anticoagulation. There are a couple guiding principles as well as a couple main anticoagulants that we might use, and so my goal in this lesson is to try and break them down so that you guys have a good understanding of what we're doing with them. And so let's start off and talk about why it is that we anticoagulate. The whole purpose for using anticoagulation is going to be to maintain longer filter runtimes. It's that simple. So if our filter is clotting, we're losing efficiency, as well as when it actually clots off, there's a period of time in which the therapy is just not going to be running. Now, typically the provider is going to build in a buffer to our flow rates and really the targeted therapy rates to try and account for this downtime, but ultimately the less it's down, the lighter that we can really run the therapy. And at its core, the problem is related to clotting, which is typically going to be the result of platelet activation, as well as activation of the clotting cascade, and then ultimately the obstruction of those hollow membrane fibers in the CRRT filter. As a result of this, our anticoagulation therapies are going to be aimed at interfering with this clotting cascade. There are obviously risks to using anticoagulation, and the risk must be weighed against the possible benefits, and then we have to monitor closely in our patients. So with the why we anticoagulate out of the way, let's talk about some of our strategies for anticoagulation. And when we talk about these strategies, there's 3 main strategies that we can use. The first strategy is going to be no anticoagulation. The second strategy is going to be our systemic anticoagulation. And then the last of these strategies is our regional anticoagulation. Now, the main benefit of our no anticoagulation strategy is that it's going to be useful in situations where our anticoagulation might be contraindicated. Some examples of these contraindications, although not an exhaustive list, are going to be things like our trauma or post-surgical patients, patients who have head bleeds, and patients who have known bleeding, although this one sometimes is not always a contraindication, patients who have liver failure, as well as sepsis with coagulopathy. Now, the major downside to a no anticoagulation strategy is really going to be the life of the filter, which is often pretty poor. And as discussed, the less downtime we have, the better this is. This may also require greater pre-dilution replacement rates, which is also going to decrease our efficiency. And the other potential downside is if the filter completely clots off and we're not able to return the blood while it's still safe, then almost a half a unit of blood is going to be lost. Now, if this is happening frequently, obviously this can lead to need for transfusion for patients. Now, for our systemic anticoagulation strategy, we're either going to want to anticoagulate our patient through the syringe pump on the CRRT machine with heparin, or systemically given to the patient with heparin or other drug options. Now, this strategy is often going to be useful in patients who require systemic anticoagulation already, and examples of this would be patients with mechanical heart valves, or if they have a DVT or a PE, where we're going to need to give them systemic anticoagulation anyways, and our CRRT is just going to benefit from that. This strategy, though, has the highest risk of bleeding and is also going to be impacted by the patient's own coagulation status. Now, if we are using a drug that has a reversal agent, the doses of those reversal drugs may be impacted by the filtering of that drug from the CRRT filter. Main takeaway here, though, is the filter life is going to be extended, but with the increased risk of bleeding for our patient. Now, as far as the drugs that you might give to your patients systemically, there's really 2 main groups that you might give. The first is going to be either heparin or low molecular weight heparin, although Lovenox really is not often used for this. And the other is going to be our direct thrombin inhibitors, and this is going to be either a bivalirudin or a gatroban or other medications of that class. Now, of these, heparin is going to be the most commonly used one, and this one has the ease of monitoring and dosage adjustments. It is easy to reverse with Protamine, but we do need to monitor these patients for HIT, and if their platelets start falling, then we're going to need to stop it. Now, for our direct thrombin inhibitors, we don't have reversal agents for these, so FFP can be helpful as well as cryo and other clotting factors, but there is no risk for HIT. Now for our regional anticoagulation. This one is probably the most common one that you're going to come across. And there are several studies out there to show that this one is safe and effective. Now with this strategy, there's actually going to be less risk for bleeding, and we can use it in some patients who have known bleeding or bleeding risk factors. Ultimately, our filter life is going to be extended with a lower risk. Now this strategy though is going to require closer monitoring of our patients. Now when it comes to using this strategy, there's actually going to be 3 main drugs that we do. The first one is going to be heparin and combination of protamine. Now, in order to understand this one a little bit better, I'm going to bring up the diagram that we had of our CRRT circuit and blood flow. Again, this is just the real basic minimal setup here. So in order to use heparin protamine in this regional anticoagulation strategy, heparin is given pre-filter, and then protamine is going to be given post-filter to reverse the anticoagulation. So looking down at our diagram, we're going to have our heparin that is going to be infused into the blood after it's drawn from the patient, but before it gets to the filter. And then the protamine is going to be going post-filter back into the blood just before it returns to the patient. And then the goal is that the dose of protamine is going to be enough of a dose to be able to reverse the effects of however much heparin you've given. And essentially the way it works is for every 100 units of heparin that you give, you're going to be giving 1 gram of protamine. The next drug to use here is actually going to be our citrate calcium combo. And trisodium citrate is becoming more and more popular. Now, in order to understand how this combination is actually beneficial here is the citrate actually binds with calcium, which is a key player in almost all parts of the clotting cascade. Now, once the calcium is bound, the citrate is no longer activated. And so what we do here is, again, looking at our diagram, we're going to be giving the citrate pre-filter, just like we did with the heparin protamine combo. And then most of the unbound citrate is actually going to be removed via the filtering process. But what we do then is we then infuse calcium post-filter, and this can either be in the return line going back to the patient or just giving it to the patient systemically in order to ensure that they have adequate systemic levels of calcium. And so here we're not going to be reversing the effects of the citrate. It's just we've now depleted the calcium from the blood being bound with that citrate that's no longer active. So we have to replenish that calcium back to the patient so that it's available for many different things, one of those being used in the clotting cascade. So this is actually very similar to how blood products work. They actually put citrate in red blood cells in order to be able to store them without clotting. And so that's why if you've ever had a patient who's been bleeding out from GI bleed, surgery gone bad, maybe a trauma patient that's not doing well, and you've given them lots and lots of blood, after so many units of blood, you have to give them that amp of calcium because there's that citrate in the blood, which is going to be binding up all that calcium that the patient normally has, and you're going to be working against yourself because you're just going to continue to bleed because now you're anticoagulating the patient. Now, sodium citrate is actually going to be metabolized into sodium bicarbonate, which can actually benefit our patients who have metabolic acidosis. The great thing here with sodium citrate is it has equal efficacy to heparin with much less risk. And the way that we monitor patients when using this strategy is that we're going to evaluate both a post-filter as well as a patient ionized calcium. And so here what I'm talking about is we're going to draw blood just after it goes through the filter and then check an ionized calcium level, and we should see it be critically low at this point because hopefully that calcium has been all bound up by the citrate. So here on this post-filter, if our ionized calcium is too high, this means we're not binding enough of that calcium. We're going to have to increase our citrate infusion rate and vice versa if it's too low. Then we're going to go over here to our patient and then draw a patient ionized calcium. And here we're targeting for normal calcium level. So if it's too low, the patient doesn't have enough calcium, so we're going to have to increase the rate of our calcium infusion, and then again, vice versa if it's too high. So again, really important that you have close monitoring of the patients when you're using this strategy because we want to ensure, one, that we have enough anticoagulation in order to get that increased longevity out of the filter, but we also really need to be monitoring our patient to ensure that they have the proper calcium level because that's really going to be important to them and their body processes as well as reducing that risk of bleeding. And then finally, the last drug group that I want to talk about real quickly is going to be our prostacyclins. So this is going to be like our EPO. Now, I can say I personally have never seen these ones given, but I have seen them mentioned in some literature, so I did want to make quick mention of them here. And our prostacyclins are actually platelet inhibitors and antithrombotic. They have a very short half-life of only about 30 minutes. but they are potent vasodilators, and if they're not dosed properly, it can lead to worsening hypotension in shock patients, which is going to be pretty common in patients who are on CRRT, as well as it can lead to cerebral edema. And with this, there does come the risk for thrombocytopenia. Like I said, though, I've never personally seen this one, so I really don't have much experience in being able to speak much more to it than that. All right, so those were our strategies for anticoagulation. As you can see, there's 3 really different strategies. Either we're not going to anticoagulate them, or we're going to give them systemic anticoagulation. So we're going to get the benefit of the preserved filter life, but also the risk for bleeding because our patient is also anticoagulated. And then we have this beauty of the regional anticoagulation, where we can still provide anticoagulation as it's going through the filter, but then give them either Protamine if we're giving heparin, or give them calcium to replace the calcium that's bound up by the citrate, and still get that preserved filter life without the risk of bleeding. Alright, so for this lesson, this is a 6th lesson in the CRRT Explained series, and in this lesson we're going to be talking about the pearls of therapy. I'm basically just going to be rambling through some pearls that I've learned over the years, or just some common things that come up when running CRRT therapy. Now, this isn't going to be an exhaustive troubleshooting list, and I'm sure I'm going to miss some things later that I wish I included, but hopefully this contains some good information for you guys. So first, let's talk about our access and return issues. And this is probably the biggest headache of running CRRT. If you're having access or return line issues, it's really going to make for a really annoying and sometimes awful shift. Now, unfortunately, this is probably something that you guys are going to come across. I definitely can recall many nightmares of just having constant issues on getting CRRT to run on patients. And really what I'm talking about here is when we have our access, which is going to be too negative, or our return, which is going to be too positive. Now, if these are too high, then these are going to red alarm on the machine, and the system is going to stop not only just the therapy, but also the blood flow. So it's going to be really important that you guys fix this quickly. Now with this, we do want to avoid flipping lines. So typically we have the red to the red and the blue to the blue on the catheter, and the flipping is where you basically switch that. You have red to blue and blue to red. And the reason for this is actually going to decrease the effectiveness of the therapy. If you remember in that second lesson where I talked about where those ports are on the dialysis catheter, we want to ideally be pulling the blood from the proximal port and then returning the blood to the distal port. Now, if it certainly comes to a matter of running or not running, then absolutely we'll flip those lines in order to keep the therapy going. But just remember that we're losing efficiency now by having those lines flipped. Patient positioning can sometimes be the cause of the issues that we have here. So if you have your line in the patient's IJ, make sure you're checking their upper body position, position of the limb, as well as their head and neck. If we have femoral access, then make sure we're checking lower body position, making sure that the leg is not bent, and there's really nothing pressing on the line. When having these issues, sometimes a good couple flushes can do the trick. And really, speaking of flushes, also make sure that you guys are flushing the lines good when you're disconnecting or doing a filter change. Our goal is to really keep that line functioning good. Now, some places still pack these lines with heparin or citrate, so make sure that you guys know what your facility process is. If you do pack, or you're unsure if you do, then you really need to make sure that you're withdrawing this and that you're not flushing this into the patient. And really, at the end of the day, if all else has failed, it's really vital that our patient is getting this therapy. If you need to advocate for a new line and perhaps a new location of that line, make sure you guys do so. Alright, so now let's talk about clotting versus clogging. And really when we're talking about this terminology, we're talking about 2 primarily different things. We have our transmembrane pressure, or our TMP, and our pressure drop. Now our TMP is basically the hydrostatic pressure across the membrane. Now this is a difference in pressure between the blood and the dialysate compartment. To really simply think about this, this is the amount of pressure required, that hydrostatic pressure, to move fluid from the blood across that membrane into the dialysate. This is the driving factor for our convection. And some of the settings on the machine are actually going to change this TMP value. So if we're adjusting blood flow rate, the patient fluid removal rate, as well as the replacement solution rate, these are all going to impact our TMP. Now, if we hit a positive pressure of 350, this is going to trigger an alert. And if we go above a positive pressure of 450, this is typically going to trigger the alarm. And this increasing TMP is what's going to be measuring that our filter is clogging. So you can really think about it as the filter begins to clog, those pores that are in the membrane that allow the water and solutes to cross are going to begin to get filled up with junk. The more of these that are filled up or the more restrictive that they become, it's going to require more and more pressure in order to move that fluid across there. Hence, as the filter is clogging, you're going to see this going up and up and up. Now, our pressure drop is a measure of the pressure required to go through the filter. So you can really think of this as the change in pressure of blood entering and then leaving the filter. And here, as we adjust the blood flow rate, that this is going to impact the pressure drop. The higher the blood flow rate, the higher the pressure is going to be initially going into that filter. Once this value reaches 200 or higher, that this is what's going to trigger the alarm, and then this is going to be our indicator for the filter is clotting. So again, you can think about, remember in the filter we have those really tiny hair-like hollow fiber membranes, and the blood is flowing inside of those tiny fibers. As they eventually begin to clot off, it's going to be harder and harder in order to move the blood through there, leading to a higher and higher pressure drop. All right, now let's talk about our prescribed versus our delivered therapy dosing. Now, while we as nurses do not directly control the rates of therapy, we can and do have significant impact on what is actually delivered versus what is prescribed. According to many different studies that have taken place, the generally accepted delivered dose goal is going to be 20 to 25 milliliters per kilogram per hour. And really, our surrogate for this delivered dose is going to be our effluent rate. Now, this dose, along with the prescribed dose, is going to be shown on the machine, and this is really why we enter the patient's weight in here. And stoppages in therapy happen frequently and are oftentimes unavoidable. Things like simple bag changes will stop the therapy until that bag is changed. The quicker we can detect this and complete these tasks, the less downtime that we're going to have. Also, a multitude of alarms will either stop therapy or even stop blood flow completely. So it's really important to be on the listen for these alarms and work to correct them quickly. Now, access and return line issues like we just talked about can really lead to significant reduction in the therapy that's being delivered depending on how much trouble your line is giving you. And so we can really do our part to minimize these disruptions in therapy. Interventions we do directly impact this. If you notice that your delivered dose is below the 20 to 25 mils per kg per hour, then you should really be alerting the provider to see if they need to increase the prescribed dose to make up for any of the issues that we're having, so that at the end of the day, we end up back within that actual delivered dose goal of 20 to 25. Next, we have our blood return. And there's generally around 150 to 165 milliliters of blood in the CRRT filter set, depending which filter set you're using and which machine. So it's really important that we're able to get this blood returned to the patient before our filter completely clots and we're unable to do so. And if it's not returned, this is really equivalent to about 1/4 of a unit of whole blood. If we're having frequent filter changes that are happening and the blood is not being returned, this can obviously lead to the patient having pretty significant blood loss and ultimately requiring transfusion. So in order to return this blood to the patient before the filter either clots or clogs off, what we do is we stop the therapy, we disconnect the access line from the patient, making sure that we flush the access line of the dialysis catheter good, and then we're going to attach that access line to a bag of fluids. Then as we go through the process of returning the blood, basically we're going to be filtering this fluid from the access all the way up in through the filter and then back through the return line to the patient, really returning a majority of the blood to the patient. Of course, it's important that we're closely monitoring during this time for any clots or how the patient is really tolerating this. Another important thing to talk about is pre-priming a filter set. So this is essentially when you get the machine and the filter all primed, ready to go, but your patient's not there in order to hook right up to. In these cases, it's really important that you don't pre-prime this filter set and leave it sitting for too long. Doing this can actually lead to a reaction in your patient potentially when hooking them up and starting the therapy. So really our best practice is to prime when you're ready to hook up to the patient. Now, a crucial part of CRRT therapy is going to be the precise management of our patient's fluid balance. And this is going to be through managing our patient's ins and outs or our I's and O's. Every hour, we're going to be meticulously adding and subtracting and figuring out what our balance is. And oftentimes we're chasing the hour that just happened. And what I mean by that is we're figuring out where our fluid balance was for the past hour and then adjusting the patient fluid removal rate on the machine to ensure that we're having the proper balance that's being ordered by the provider. And so it's really important that you don't miss anything. You've got to make sure that you're thinking of all the flushes that you do, any drains that they might have. Make sure you include all of those. Now, in order to get the most accurate volume that's infused through the pumps, if you have the ability to do so, make sure you pull that exact volume that's infused. A lot of the pumps are able to go in there and look at how much volume has actually been given and then reset that number so that way when you do your next check in an hour, you'll have the exact volume that was given. Now, some caveats to this are going to be if you're giving someone fluid or albumin for hypotension, please don't pull that fluid back off. The whole point of giving them that fluid is to give them the volume that they might need, and if you pull it right back off through the CRRT, you're basically nullifying what you just did. And the same goes for blood or FFP, again, if you're giving it to your patient because they're hypotensive as a result of that. If you're just giving them a standard transfusion because they're having hemoglobin drift, then it's okay to pull that volume off for the blood that you've given at that point. Now, if you're having to change your filter, it's really important that you get the actual volume of fluid that was removed from your patient before you begin the process. This way you can accurately calculate how much fluid your patient was positive during the time that the filter was down. Now, if the therapy is going to be down for an extended time, don't try and make up all that fluid in 1 hour. Try to spread that out over a couple hours. And then probably most importantly is every hour you want to figure out whether you were over or under your set fluid removal rate. So did you pull more or less fluid than you were supposed to? You want to then figure out what that difference is and either add or subtract that to the next hour. This is really important because if you're short pulling fluid 10 to 20 milliliters an hour for an entire day, that's really going to add up. Now, what if you have a crashing patient? Now, if your patient's going down, and your therapy is ordered to be pulling fluid and running your patient negative, stop pulling that additional fluid. Now, if things are continuing to deteriorate and your patient is near coding, then at this point you might want to just stop all the fluid removal until you see which way things are going to go. Now, oftentimes these very sick patients are getting large volumes of fluid with the drips that they're getting, so obviously we don't want to do this for very long, but doing this can be a quick code prevention in the moment. Now, speaking of codes, if your patient does actually code, then you want to turn your blood flow down as low as it goes. And really, as soon as you get the chance, you want to return that blood. Because really, compressions and CRRT running smoothly do not go together. The last thing you want while your patient is coding is to be constantly dealing with the CRRT alarming. Now, in the last lesson, we talked about the anticoagulation strategies for CRRT, so I do want to talk a little bit more here just about some pearls for our citrate anticoagulation. So it's going to be important that you ensure that you're using dialysate and replacement solution with no calcium in there. The calcium that's in the normal premix bags can bind the citrate, basically making it less effective. Now, if you're using a hypertonic citrate solution, such as trisodium citrate, close monitoring of our patient's sodium level is also going to be important. These solutions can actually lead to hypernatremia in our patient, and if they do become hypernatremic, you're going to need to reduce the sodium that's in either the dialysate or the replacement fluid. Now, in my facility, when this becomes necessary, we have a protocol to basically switch between normal saline, half normal saline, and D5W as our replacement fluid based on where our patient's sodium level is. Now, the other important thing here is when you're starting or stopping your therapy, it's absolutely vital that the citrate and the calcium infusion are stopped and started together. Don't ever run one without the other, even just for a little bit. Now, always make sure that you have a hand crank with your machine. The last thing you want is the machine to die and you have no way to return the blood that's in there. Now, because we're extracorporeally filtering the blood, hypothermia is a common concern. Both blood and fluid warmers are often used, and sometimes though this is not enough and a warming blanket or some sort of warming machine is also going to be needed. Now, knowing this though, it's important to know that CRRT has a way of actually masking fevers. If you're finding that your patient is normothermic without any sort of warming device, I'd be worried that your patient is actually febrile underneath. Also, don't sit on bag changes or effluent bag empties. In this state here, the blood pump is still running, but the therapy is not. And the same goes for clearing alarms. The yellow alarm could mean that therapy is not running for your patient. Now let's talk about the blood leak detector or the BLD. Now this part can be finicky, especially when it's not cleaned properly. You want to take an alcohol swab to this between runs. The effluent coming from your patient should be either clear or yellow. If you do get the BLD alarm on your machine, or you think that you see pink in the effluent bag, that this could mean that you have a ruptured membrane. Send a sample of the effluent to the lab to check for blood and change the set if it is detected. Now, word to the wise, don't forget to clamp the syringe tube line if you're not using it for the CRRT machine. And along those lines, always check the connectors, especially on a new set. I've personally had the Y connector come off during priming. Also really important, never use an old effluent bag when you're priming a new set. Remember that we're attaching that return line to this bag for the priming process and then disconnecting from there and attaching to the patient. This is a major no-go. And then lastly, if you're having to put up a new filter set when you've been already running, you don't have to use new full bags of replacement and dialysate when you're putting that new set up. Don't waste those old fluids. Just make sure and cap off the ends while you're putting the new set in place, and then put those same used bags back on the scales with the new filter. The machine is pretty smart like that, and it's going to be able to figure out how much fluid you have. Alright, so those are the main pearls that I wanted to just kind of talk to you guys about that sort of came up while I was making the lessons for the last few lessons here, and I really wanted to kind of share some of this information with you guys because, again, like anything else that we do, so much of the experience that we gain is really through just doing things over and over and coming across new things or learning from those who came before us. So my goal here was to sort of share some of the things that I have learned over the years to hopefully give you guys some good information to be able to carry that forward in caring for your own patients.